can all be the cause of osteoporosis. As I told you, mastocytosis, you have to think about tryptase elevation and urticaria pigmentation. Extended workup, overnight dexamethasone to rule out Cushing syndrome. If it is post-dex cortisol is more than 1.8 micrograms elevated per Cushing, look for testosterone. If it is low, helps you to diagnose male osteoporosis. Anti-TG and total IgA if malabsorption is suspected. If there is an IgA deficiency, use IgG-based assays. Serum tryptase tells you diffuse osteoporosis will take a sclerotic lesion more than 20, systemic mastocytosis. Urine-free cortisol will tell you confirm Cushing. IGF-1 and J stimulation for growth hormone deficiency, homocysteine in B12 deficiency, vertebral fractures, and disproportionate BMD. So, key finding is elevated homocysteine and independent fracture rates in all these patients. What are the bone turnover markers? Bone turnover markers that predict fracture risk independently of the bone density. High baseline bone turnover markers prefer anti-resorptive therapy. If the bone turnover markers are low, anabolic therapy. Majority of the times, we don't have facility for doing the bone turnover markers because it is not a standardized test which is being done. So, though it is said if the CTX is high, it is type is resorption. If PNPA1, think of formation. Well, osteocalcin, bone specific alkaline phosphatase, NTX, which helps you to do the resorption CKD in Page's disease. There are all supplementary tests, but quite cost not available basically in the problem in the country uniformly across laboratories. So monitoring the treatment, if the bone turnover markers fall more than the least standard coefficient, that is 25 to 40% at the third or 6 months, and adherence is confirmed, then it's good. Fracture and treatment with adequate beta bone turnover markers, reassess the BMD quality and secondary causes, rising the bone turnover markers after Denosumab, rebound, act promptly. So if there is a bone turnover markers are very, very important. If they are rising after Denosumab, it means there's a rebound effect and act very quickly. Who should be treated? Anybody with a BMD of less than 2.5 in the spine, femoral neck, or hip or 1/3 radius, or a past history of regulatory factors, hip or vertebral, regardless of the T scores. High fracture risk, 10-year major osteoporotic fracture possibility of more than 20, or in the hip more than 3 by the ultrasound threshold. High risk medications like glucocorticoid, more than 5 milligrams per day, or prednisolone more than 3 months, initiate early. Imminent fracture, prior vertebral or hip fracture, the T score less than 3, and fracture within 2 years, consider anabolic therapy, which is the AAC guidelines. So anabolic first, sequential anti-resorptive therapy, give a drug holiday and reassess the cycle. Anabolics build the bone, anti-resorptive preserve the bone. Sequential therapy is superior to monotherapy in very high risk patients. Never discontinue Denosumab without a transition plan. What are the drug classes? We have the bisphosphonates, the Denosumab, the teriparatide, and the Denosumab. These two are the anti-resorptives. These two are the anabolic agents. Bisphosphonates inhibit osteoclast perennial phosphatase synthesis proteases. There is a first-line anti-resorptive. You have the oral and the IV. So we prefer IV because it's a long-term, once-a-year dosage rather than taking daily. Denosumab is once in 6 months. Is potent, reversible suppression, and is given subcutaneous every 6 months. Teriparatide is an anabolic agent. Teriparatide and albuparatide, they are analogs. Anabolic via treatment, receptor activation, and daily injection for a period of 2 years. Denosumab is given as anti-sclerosing antibody, dual action resorption, monthly subcutaneous for 12 doses. So the drug comparison table, which is a key in clinical parameters, alendronate perorally, risenronate weekly and monthly. Zoledronate is annually. So the BMD gain is roughly between 6 to 8%. The problem with alendronate is you will have the J intolerance, renal caution, and osteonecrosis of the jaw. Risenronate also, J profiles better than alendronate. Whereas zoledronic acid, will have only flu-like reaction and nothing more. There is a drug holiday after this, after 3 to 5 years. Later, whereas in Denosumab, there is no drug holiday. You keep continuing. If you stop it, you'll have a rebound fracture and discontinuing. And the prediction is about 40%, which is very good. Teriparatide and albaparatide are anabolic agents which are given in every day. There is an increase of about 15%, and the hip fracture reduction is about 30%. Follow up with anti-resortives after 2 years. Albaparatide not available in India. Rosasumab is subcutaneous monthly, but period of 12 months. Avoid if there is a previous myocardial infarct or stroke. So anabolic first surgery, who are the persons who qualify? Have very high fracture risk, T-score less than 3 or minus 2.5 multiple fracture, prior vertebral or hip fracture, fracture and anti-resorptive therapy, multiple vertebral fractures at presentation, imminent fracture risk, fracture within the last 12 to 14 months, 24 months. Given as 20 micrograms subcutaneous, freedom trial data supports vertebral non-vertebral reduction. Rosasumab is given 2 to 10 micrograms subcutaneously every 12 months. Arch trial superior to alendronate in fracture reduction. After anabolic therapy ends, always change out anti-resorptives like denosumab or bisphosphonates to consolidate bone gains. Denosumab, the clinical concept is it's a rank like an antibody, completely reversible suppression of the osteoclast differentiation, unlike the bisphosphonates, and there is no skeletal reservoir. What you have it for zoledronic acid. Discontinuation, rebound rise from the baseline within 6 to 12 months from the dose, rapid bone loss, multiple vertebral fractures, that is rebound phenomenon. Transition protocol, give alendronate acid 6 months after the last dose of denosumab. Repeat if the bone trauma markers are not suppressed at third month post zoledronic acid. So if you're giving denosumab, within 6 months, you give zoledronic acid and check the bone turnover markers 3 months after giving zoledronic acid. If it is not suppressed, you will have to repeat it. If it is suppressed, you can stop it. Risk is hypercalcemia. Pre-treatment, all patients with calcium intake should be about 1000 to 1200 milligrams and a vitamin D of more than 800 milligrams per day for initiation and throughout. So, denosumab rebound effect is evaluate the fracture risk before stopping, give zoledronic IV after 6 months as the first dose, check the CTX post zoledronic acid of the switch. Do not simply stop denosumab. Rebound risk is high in patients who receive more than 3 years of therapy and those with vertebral fractures. Bisphosphonates, the drug holiday evidence and criteria. Oral bisphosphonates for 5 years, you can give it. Holiday if there is a low or moderate risk. IV bisphosphonates for 3 years. Consider holiday if the BMD is stable and no risk factors. High risk patient, continue oral bisphosphonates after 10 years and switch to IV. When will you resume? Again, the T-score declines to osteoporotic range, new fracture during holiday. Bone turnover markers rise significantly above the upper normal, holiday more than 5 years. Residual effect ratio, bisphosphonates bind to hydroxyapatite and are released slowly over years. This skeletal reservoir provides continued anti-fracture protection during holiday. The anti-fracture risk peaks 5 years after oral bisphosphonate use. Hip is the most common site. Consider lateral femur X-ray if the thigh groin develops because of atypical fracture neck of femur can be picked up. Atypical fractures, they are subtrochanteric, diaphyseal, transverse or oblique, prodromal thigh, groin pain 50%, bilateral in 30%. BP, that is, bisphosphonate is more than 3 years, cumulative dose dependent. Action, teriparatide may accelerate the healing. You will have to shift over to that. Osteonecrosis of the jaw, more with oral bisphosphonates, exposes the necrotic bone 8 weeks despite the treatment. IV bisphosphonate and denosumab at oncogenic doses or in osteoporotic doses. Osteoporotic dose, the bisphosphonate, the fracture risk is 1 to 2 per 1000 patient years. Optimize dental hygiene before initiating and avoid invasive procedures. Monitoring of the patient with treatment. BMD of the spine, baseline, 2 year on treatment, then every 2 to 3 years, stable on increasing the BMD. CTX and P1 and P, baseline and every 3 to 6 months. More than 25% fall, antireceptives. In P1P, the anabolic agent, the formation should raise this anabolic, and if it is false, it means antiresorptive effect. Vitamin D baseline 3 to 6 months after repletion, target more than 40 milligrams. Serum calcium 1 to 2 weeks post Denosumab as zoledric acid. Normal calcium have to be maintained. Renal functions before each IV bisphosphonate dose. And the GFR should be more than 25. Inadequate response, non-adherence most common, confirmed with bone turnover markers. Inadequate calcium vitamin D supplementation. Undetected secondary causes. Recheck the laboratory. Malabsorption oral bisphosphonate. Switch to IV. Treatment failure. Consider anabolic switch. Least significant change must be factored. More than 3 to 6% of spine and 4 to 5% of hip of most DEXA missions. Calcium and vitamin D form the foundation of the therapy. An elemental calcium of 1000 milligrams, dietary preferred if not supplementation. Vitamin D 2000 international units, we go up to 4000 per day. High doses if deficient and monitor the vitamin D levels. Target should be more than 40 whenever you check them annually. Calcium supplementing timing split into low 500 milligrams less in 2 doses. Carbonate with food, citrate anytime. CKD low acid. Pitfalls. Total calcium dietary supplement should not exceed 2000 because of the risk of nephrolithiasis and vascular calcification. High dose bolus vitamin D not recommended and is associated with increased risk of fall. Calcitriol preferred in CKD despite 4 to 5 doses. Avoid if hypercalciuria. Vitamin D toxicity is more than 150 nanogram. Hypercalcemia is a hallmark. Osteoporosis in chronic kidney disease in patients with stage 5 kidney disease, GFR of less than 15. You exclude the CKD and then specialized management, give calcium mimetics, give secondary hyperparathyroidism. In stage 4, no bisphosphonates, teriparatide denosumab can be used. In stage 3A to 3B, bisphosphonates with calcium, PTH, and caution with calcium, PTH, and phosphorus. Stage 1 to do standard workup as you give it. Key principles is diagnose CKD before handling patients with osteoporosis. PTA bisphosphonates avoid if the GFR is less than 30. Denosumab usable in CKD does not depend upon the renal clearance. Monitor the calcium closely. Severe hypercalcemia risk. Teriparatide limited data in advanced CKD use with caution. Denosumab not studied in EGFR less than 30 and cardiovascular disease avoids delay. Correct treatment secondary hyperparathyroidism and hyperphosphatemia before initiating treatment with osteoporosis drug. Again, the glucocorticoid-induced osteoporosis, people more than age 40 years of age on more than 30 milligrams of glucocorticoid per day with a T-score less than minus 2.5 and more than 40 years of age with 7 to 3.30 milligrams of glucocorticoid per day with T-score of 1 to 2.5. Those less than 40 years of age with short course of glucocorticoid use and no prior fracture with T-score more than 1. Any dose of glucocorticoid for more than 3 months, initiate calcium and vitamin D. Medium risk and high risk add oral phosphorus, resendernate preferred. IV zoledric acid if oral intolerance. Very high fracture, risk of fracture on bone turnover markers or on bisphosphonates. Teriparatide is approved drug for glucocorticoid-induced osteoporosis. Osteoporosis in type 2 diabetes, the paradox is BMD often is normal or elevated, trabecular bone score reduced, poor quality. Fracs underestimate the risk, use trabecular bone density. Then the medication effects like the bioclitazone and the SGLT2 inhibitors and the GLP-1 which are neutral. The other to increase the risk of fracture. Peripheral neuropathy, hypoglycemia, orthostatic hypertension, high risk fall, screen and address modifiable factors. Standard anti-resorptive anabolic therapy applies, no drug modifications required. Trabecular bone score monitoring preferred over BMD alone in type 2 diabetes. Male osteoporosis, the key differences from female is underdiagnosed, undertreated, 20 to 30% of all fractures in women, in men. Secondary causes is 60%, and hypogonadism, alcohol, glucocorticoid use, androgen therapy. Use male specific DEXA norms for the T-score interpretation. Screen all men with more than 70 years with DEXA earlier if the risk factors are present. Treatment, bisphosphonates, denosumab, teriparatide, rosapipam, same thing as what you've come across. Treat hypogonadism with testosterone supplementation concurrently, and EDT for prostate cancer. Initiate bisphosphonates, denosumab, prophylactic and start therapy. So in elderly patients more than 75 years, fall prevention is a priority. Muscle strength has to be increased by vitamin D supplementation, which also reduces the fall by about 23%. Then hip protectors most benefited in insulation elderly advanced patients. That is the key limiting factors considering in high fall individuals. Polypharmacies, namely the benzodiazepines, antidepressants, antipsychotics, etc. They all risk agents. They describe deprescribe when possible. Fracture liaison services capture the initiative. Systematic post-fracture identification, initiation of post-treatment osteoporosis reduces refracture by 40%. Teriparatide and denosumab are proven safety in women more than 75 years. Bisphosphonate GI tolerability declines with age, hence consider IV donor-tonic acid. Postmenopausal osteoporosis, which is commonly seen, where the Z score is seen, not the T score, is the diagnostic metric. Evaluate the secondary causes also. FHA, celiac disease, and hyperprolactinemia and malabsorption. In a postmenopausal woman, also, if the BMD is not increasing, you have to consider the factors of the secondary causes. Treat the underlying cause first. Avoid bisphosphonates unless secondary causes are corrected. Teriparatide off-label, but evidence supports use in severe cases with fractures. So then what do we use most often is the denosumab. Pregnancy-associated osteoporosis is rare, presents as multiple fractures. Calcium, vitamin D, breastfeeding cessation, most recover spontaneously. If severe fracture persists, teriparatide postpartum, avoid before next pregnancy. So the key problems in India is low peak bone mass because we have low vitamin D deficiency. They have low bone turnover marks compared to the West, and Asian frax model should be used than compared to others. There is vitamin D deficiency more than 70% of all age groups. Dark screen indoor patients with low dietary calcium intake, aggressive repletion before any polypharmacy. IDF, International Osteoporosis Federation endorsed national supplementation guidelines should be used. Drug availability and costs, generic alendronate widely available. Zorantate costing reduces teriparatide and rosupimab remains expensive. Denosumab available in major centers, also in Jana Aushidhini centers. Guidelines, they say the menopause recommends, POXI recommends DEXA screening of all menopause for all high-risk women. FRAX model, India model, calcitriol preferred in elderly Indian patients with compromised renal function. Vertebral fracture assessment is based on the lateral spine of DEXA, detects prevalent vertebral fractures at low radiation, Glenn classification grade 1, 2, 3, one or more grades of 2 and 3 fracture risk, indication to treat regardless of the BMD, recommended in one more than 70 or men more than 80, height loss of more than centimeters, 4 centimeters, or a T-score less than 1.5 with risk factors. The trabecular bone score is a textural analysis of lumbar disc, surrogate for bone microarchitecture quality. Trabecular bone score of more than 1.3 is normal, 1.3 to 3.2 to 3.3 is partially degraded, and it's like more than 1.2, it is degraded. Particularly useful in type 2 diabetes, BMD overestimates bone quality, especially in hyperparathyroidism, glucocorticoid. Trabecular bone score adjusted fracts, multiply the fract standards by the trabecular correction factors, and recalibrate the risks. Currently available in Medi software on a compatible device. Now, sequential and combination therapy. Sequential therapy is teriparatide, denosumab, teriparatide, alternate. Rosuzumab with alternate rosuzumab. If you see anabolic agent with an anti-resorptive, bisphosphonates with an analog. So there are various trials where you find there is an increase in the BMT when you follow a sequential regimen. And these are the recommendations given in patients of different categories. Conservative treatment algorithm, very high risk anabolic, then anti-resorptive. Very high risk bisphosphonates, then spam a drug holiday. Moderate oral or IV bisphosphonate. Low risk lifestyle and reassess at the end of 2 years. Adherence, the greatest is the challenge. 1 year adherence, half the patients remain on oral bisphosphonates for 12 months. Fracture risk increases. Non-adherent patients have 40% higher fracture rates than the counterparts. Fractures not treated up to 80% of the patients presenting with fragility factors is osteoporotic therapy. So simplify the regime weekly, monthly, orally, annually. Adverse side effects and the FLS programs and the bone turnover markers feedbacks to the patient. Non-pharmacological weight-bearing exercises reduce alcohol to 3 units per day. Significant fracture risk increases. And then if you recommend less than 2 units per day, that's probably the best. And thiamine, vitamin D. And essential is the alcohol dependence. Cessation of smoking, it reverses the bone loss. And when you do all this, you do a nutritional bone optimization by protein uptake of more than 1 gram per muscle mass and excess limit of sodium, adequate diarrhea equal in calcium scores. Post fracture, identify, investigate, and initiate the fracture risk patient. Most highest short-term mortality in fracture is second fracture within 2 years, and FLS reduces fracture K model, the refracture by about 30%. It is the best framework of level 1, identify and investigate and initiate therapy. So the summary is screen and risk and satisfy, use FRAX, exclude the secondary causes, treat the imminent risk factors, never stop Denosumab abruptly, monitor the bone tumor markers, individualize the comorbidity, and optimize the foundation. Thank you.
Thank you very much, sir. Thank you, sir. You are able to hear, sir? Okay. Thank you, sir. Any question is there? I'll call you, sir.
Thank you, sir. Thank you. The great session you have
I
taken.
can't hear you, sir. I can't
Okay.
hear you.
Okay. I think, sir.
Rahulji.
Sir, am I audible?
Hello.
राहुल जी
Yeah.
हाँ क्लोज कर दीजिए
ठीक है ठीक ठीक